It's an emergency, it's an emergency, it's an emergency. Sister, help me. Doctor, help me. Does this sound familiar to you? Oh yes, it does, especially in accident and emergency department. Today, I am going to present to you management of myocardial infarction. We should always be open to updates. As much as we are dealing with human beings, we are always ready to get updates. So it means even in 5 years or in 10 years to come, if there is any update, we should always get updated. This is 1st of January 2024. So in future, if you get any updates, please welcome. Our main goal is to lengthen the life and prevent myocardial infarction. Can we start? Monacbaca is an acronym that we use in management of myocardial infarction. To start with, let's understand what myocardial infarction is. It lies under acute coronary syndrome. So it occurs when an artery that sends blood and oxygen to the heart is blocked, or it's an acute occlusion of the coronary arteries. This is lack of blood flow. It causes the die. How will the patient present? Have you ever had a patient presenting to you and all the complaints they raised were definitive of myocardial infarction? So the symptoms are: patient comes in with chest pain that may be described, and it feels like pressure or tightness, pain, squeezing or aching on the chest. Another one will tell you, I have pain or discomfort that spreads to the shoulder, arm, back, neck, jaw, teeth, or sometimes the upper belly. Some patients come in with the diaphoresis, they're sweating profusely, cold sweating, dry mouth, cold extremities, fatigue. Others will come with heartburn, or they feel that they are having epigastric pain. Some of them come with lightheadedness. Some feels nausea and shortness of breath. So we have types of acute coronary syndrome. The first one is STEMI. Number 2 is non-STEMI. Number 3 is unstable angina. For STEMI, how we diagnose a STEMI? First, there is an ST elevation when you do your ECG. That is 2 small boxes above the isoelectric line. When you do a lab works, troponin is usually high. Let's go to NSTEMI. NSTEMI, you diagnose it by doing an ECG, and when you do an ECG, you get ST depression. It is less than 2 small boxes below the isoelectric line, or mild ST elevation. When you do the lab work, the troponin is usually very high. You may get an ECG that is showing signs of myocardial infarction, and when you do a lab work, troponin, you find it is normal. It is advisable to repeat it after 6 hours because it may rise. We once had a patient who had a troponin that was normal. The ECG was showing of myocardial infarction, but a repeat of the troponin, it rose to 16. You can see how that serious is. Let's go to unstable angina. This is a chest pain that occurs even at rest. It is not relieved by any analgesics. In unstable angina, there is no ECG changes and no troponin rise, but is an early warning sign. Therefore, any patient coming in with chest pain, let them be evaluated in the right way. So management of myocardial infarction should be here at our fingertips. That is why I am presenting this to you, and especially accident and emergency nurses. My name is Nurse Irungu. Welcome to my YouTube channel. If you have not subscribed, please do so, so that you are notified in case I upload any video. Let's now go to the causes of myocardial infarction. What are the causes? It is caused by reduced blood flow to the heart. What causes blood flow to the heart? Have you ever asked yourself? Point number 1 is atherosclerosis. This is a plaque buildup in coronary arteries. Another one is rupture of coronary arteries. Another one is a clot in coronary arteries. You see, rupture in the coronary arteries will interfere with the blood flow to the heart, end up dying. What about the clot? It also can occlude the blood flow in the veins, the coronary arteries of the heart, therefore leading to myocardial infarction. Another point is remodeling or narrowing of the coronary arteries. Risk factors. Have you ever asked yourself the risk factors of myocardial infarction? They are as follows, and I will explain them. We have hypertension, we have diabetes, we have high cholesterol, we have cancer, we have sickle cell, we have obesity, smoking, alcohol. Let's go to point number 1, hypertension. It leads to interrupted blood supply to the heart. That is myocardial chambers. This triggers vasoconstriction of the coronary arteries. How about diabetes? Increased circulating fat or triglycerides. Another point in diabetes is increased sugar causes inflammation inside the vessels, hence platelet aggregation causing clot formation. Another point is increased cholesterol, simply blocks coronary arteries. Cancer, it may lead to inflammation of the vessels or hardening of the blood vessels. Remember how hard it is to cannulate a patient who have undergone chemotherapy. Do you remember? Sickle cell anemia. You understand, red blood cells is the oxygen carrying capacity. So thickening of red blood cells may block coronary arteries, especially when they are in crisis. Obesity, increased triglycerides or overweight may cause myocardial infarction. How about smoking? It speeds up the clogging and narrowing of the coronary artery. So if you are a smoker, it's a high time you avoid smoking. Family history. If anyone has had myocardial infarction previously in your family, you may also be at risk of getting myocardial infarction. Alcohol, for example, alcohol damages your heart because parts of the heart stretches and enlarges, weakening heart muscles, keeping it from pumping as well as it should, or decreased cardiac contractility. Let's now go to how do we diagnose myocardial infarction? By simply doing an ECG. An ECG should be done within 10 minutes of arrival to the hospital facility. Within 10 minutes. Are we together? For STEMI, we said it is 2 small boxes above the isoelectric line. For non-STEMI, 2 small boxes below the isoelectric line. For angina, unstable angina is continuous chest pain that is not relieved even by medication. We also do a test called troponin levels immediately and repeat after 6 hours. Troponin is detected within 4 to 6 hours after onset of chest pain. Peak concentration is approximately 12 hours and remain elevated for 3 to 10 days following a myocardial infarction. I hope you are getting all this. There's another test that is done, lipid profile. Why? To check the cholesterol and triglyceride levels. Another test is done is full hemogram to check if there's infection, and also HB, and also to see whether there is anemia and increased platelets that may lead to myocardial infarction. RBS is done, and when you do an RBS, you will leave a note whether the sugar is high so that the patient can be further evaluated. UECs is done to check the electrolytes, that is potassium, sodium levels, and creatinine. You understand how this potassium works along in the heart. Chest X-ray is done to note whether there is cardiomegaly. Echo is also done to check the heart chambers and ejection fraction. I hope I'm health educating you. I hope I'm supporting you so that you are able and you're in a position to manage your patient and understand what you should do before even the doctor comes. You're already aware of what I should be doing so that we can hasten the management of this patient. So let's go to management of this patient. I'm finding myself repeating, but don't worry, as long as those points that I'm repeating are the most important points. So we said an ECG should be done within 10 minutes. When you get the patient, position your patient in the Fowler's position, connect to the cardiac monitor, do an IV access, draw blood samples, activate cath lab to include the nurse, the cardiologist, the radiologist, and the anesthetist. What is the goal of managing this patient? The goal should be to increase perfusion to the myocardium. Another goal should be increase oxygenation to the myocardium. Another goal is to decrease the workload of the heart. That is the myocardium. Another goal is to prevent cardiac remodeling or myocardium. So we go to the newest acronym. I have learned this, and if I am wrong, I'm standing to be corrected. So you will comment down below if you have an additional ad, and it's open to everyone who is watching this video. If there's any update, please comment down below so that whoever is viewing this can also read the comments and learn about the updates. Initially, when I came to accident and emergency, that is Mater Hospital in accident and emergency, I can remember that very well. I was taken through this emergency room by Sister Muli. She was my mentor then, so I learned this through her. I had never heard about it, and I'm so happy that I learned about it. She taught me, and I found myself applying this to all the patients that I found. Later, I learned another acronym, that is Monacbaca. I'll tell you the meaning. So let's start with Mona. M means morphine. It's an analgesic. It also attenuates vasoconstriction and increase afterload of the heart. O means oxygen. If it's below 94%, please give oxygen. Or else you can also give to just support that heart that is already in distress. N means NTG spray or nitroglyceride spray. It is given 2 puffs under the tongue. If a patient is having low blood pressure, we rarely use that. Always contact your cardiologist to help you in that. Aspirin is usually given 300 milligrams. It impairs platelet aggregation. That is A. So we have finished the MONA, M-O-N-A. So C stands for clopidogrel, 300 milligrams. It impairs platelet aggregation. Let's now learn about BACA. B means beta blockers. These slow down heart rate. For example, carvedilol and atenolol. A means ACE inhibitors. This decreases peripheral resistance. For example, enalapril. They also prevent cardiac remodeling. For example, permanent change of myocardial texture. So far we have learned about MONAC, and we have also learned about BA. So we are remaining with CA. CA means clexane. Clexane prevents any associated venous clotting. And how do you give clexane infarction? Answer in the comment section. Some will give it as an IV, some will give it as sub-Q. I leave this for discussion. And always rely with your cardiologist or with your MO to help you in this. Atorvastatin. Now the last A is atorvastatin. It slows down the production of cholesterol in the body to decrease the amount of cholesterol that may build up on the walls of the arteries and block blood flow to the heart. So far so good. We have now given our patients everything that the patient could require for us to save this patient as an emergency. Remember, it is an emergency. Therefore, we ought to act very quickly. Now, we cannot work alone. We need multi-department collaboration. Remember, we need X-ray department, we need lab, we need cath lab, we need the covering of the hospital. The management should be aware that we are handling an emergency. Therefore, we should always inform every department to be ready and prepare for this emergency. In cath lab, this patient should land within 90 minutes or less for a better outcome. So always activate cath lab. Cath lab, this is where tests and procedures including ablation, angiogram, angioplasty, and implantation of pacemakers are carried out. Wait. Did we activate our ICU department? We have not activated, yes. This patient may land either in ICU or HDU depending on the extent of the myocardial infarction. So therefore, it's always important to activate ICU as well. Have you learned something? This is what I have learned so far, and I appreciate very much. For me, accident and emergency matter hospital have really helped me learn a lot. We will always be delighted to receive a patient with myocardial infarction. Accident and emergency matter hospital department have equipped us to be who we are today. We have really learned a lot. The staffs there are so welcoming. If you have anything to add, please do so. So far so good. If you have not yet subscribed, please do so. Share this information to at least to a nurse that you know, so that we save these patients who come with myocardial infarction soonest possible. And if you can be able to manage myocardial infarction, refer within an hour of presentation to the hospital. Just do what you can, then refer this patient where there is a cath lab. It is always said, knowledge is power. You are now empowered. Take this Listen it, listen and listen and listen. Use this to your patient. If there's any update, just welcome it. Make use of the update. With this knowledge, we are going to decrease the mortality of patients who come with myocardial infarction. Knowledge is power. Could you please apply this? Now you are more knowledgeable. Will you please share this to anyone who would be willing to learn about management of myocardial infarction? Till we meet next time with a video. Bye bye.